Good afternoon, everyone, and welcome. I am Lucas Brand, the Strategic Director for the American Cancer Society's National Prostate Cancer Roundtable, and I'm going to serve as the moderator for today's session, in which we're going to be discussing prostate cancer risk assessment and screening from a lens of the healthcare provider. This is the National Prostate Cancer Roundtable's first webinar, so we're extra excited today. And I think it's really appropriate and fitting that we're going to be talking about such an important topic. There's been a lot of controversy around the use of the PSA test in prostate cancer screening. So we're going to try and clear some of that up by sharing a few perspectives on how to best integrate this into clinical practice through the lens of shared and informed decision-making with your patients. Before getting started, we obviously need to thank our sponsors here, without whom's support, we would not be able to do things like this webinar and the work of the roundtable. So thank you so much to Johnson & Johnson, Pfizer, and Bayer for supporting the roundtable and our work. Here's a few ground rules for today. ACS is a nonpartisan organization, so we want to stay away from partisan discussion and keep it focused on the science and on the medicine. We also have a rules for engagement document that you can find on our website. Basically, it boils down to just be kind and realize that we're all here for the same purpose, which is to better the lives of patients and improve outcomes from prostate cancer. So we're all on the same team here. Finally, this webinar is being recorded. We'll be sharing it on our website after the webinar has concluded. So just please be mindful of your conversation and respectful of others' privacy. And of course, do not mention any specific patient information that could be identifying. Some housekeeping for today. Please just keep your webcams off and your microphones muted. Throughout the duration of the webinar, we have a Q&A box and a chat pane that you can enter your questions and comments into, and we will try to pass those along to the speakers as best we can. Q&A will happen at the end of the webinar, and again, please just remain courteous while you're engaging in the chat box. On the docket for today, as I mentioned, we're talking about the PSA test and its role in prostate cancer screening and how it is an important and life-saving tool that we can use to detect cancer early, particularly in at-risk patients when it is still curable. We want you to be able to implement some basic risk assessment workflows to identify patients who may be at risk and use that information to engage them in a shared decision-making discussion that works for the patient, that is supportive of their views and their preferences, but ultimately results in in the patient being informed and being able to make an informed decision about whether or not screening is right for them. Quick shout out to our ACS NPCRT team. You may have guessed I'm the one in the middle already. We also have our Vice President, Sarah Schaefer, who chairs the National Roundtables and Coalitions Business Unit, providing us with lots of support. And especially Naya Green, my colleague, our program manager, who has done just a ton of work behind the scenes to make this webinar happen today. So many thanks to Naya for all of her efforts. We have a pre-test poll for you. So the goal here is to gauge kind of what your knowledge of PSA testing and prostate cancer screening is. This will help us to determine how well we've done in terms of educating you on our learning objectives today. So please do complete both the pre-test poll and the post poll that we will give you at the end so that we can make sure that we're hitting our marks here. So I'll give you a couple minutes to work through these few questions. All right, fantastic. Thanks everybody for taking that poll. We'll go ahead to the next part of our discussion today, which is our experts. We've been fortunate enough to have two really field-leading folks join us today to lend their insight and expertise to this discussion. The first that you'll be hearing from is Dr. Richard Wender, who is the Chair of Family Medicine and Community Health at the Perelman School of Medicine at the University of Pennsylvania. Dr. Wender has dedicated his career to leading the medical and public health efforts that strive to improve the quality of primary care implement population health, and address social determinants of health in the continuous pursuit of equity for all people. He's an expert in cancer screening and prevention, and Dr. Wender became the first primary care physician to serve on the National Board of the American Cancer Society, and in 2006 became the first primary care physician elected to serve as the national president of the American Cancer Society. He helped lead a cancer control team that built the first ever national lung cancer, national HPV vaccination roundtable, and the National Patient Navigation Roundtable, catalyzing public health efforts in all of these areas. All of his work is anchored in being a family physician. He's been providing excellent primary care in the Philadelphia area for the past 44 years and continues to provide comprehensive primary care at Penn today. Following Dr. Wender, you're going to hear from Dr. Timothy Rebbeck, who, after spending 20 years at the University of Pennsylvania, Dr. Rebbeck joined the Dana-Farber Cancer Institute and the Harvard T.H. Chan School of Public Health in 2015 as the Vincent L. Gregory Jr. Professor of Cancer Prevention. He's the founding director of both the Zhu Family Center for Global Prevention at Harvard T.H. Chan and also the Center for Global Health Equity at Dana-Farber Cancer Institute. Dr. Rebbeck's research focuses on understanding the causes and prevention of cancer with a particular emphasis on cancer genetics, prostate cancer disparities, and global health equity. He leads large-scale international studies and consortia that have identified genetic, molecular, and epidemiological risk factors, including influencing cancer risk prevention and disparities. Dr. Rebbeck has mentored over 65 trainees, many of whom now hold academic positions, and has maintained continuous funding from the NIH since 1994. Just a reminder, excuse me, I forgot to advance the slides there. As a reminder, we'll have time for questions at the end of today's webinar, so please do continue to put those in the chat window and the Q&A window so that we can discuss them later. Last thing, just to go through the disclosures, neither speaker has anything to disclose. So with that, I will turn it over to Dr. Wender.
Thank you so much, Lucas. Make sure that I'm sharing successfully here. You are screen sharing. That seems like a good sign. Are you seeing the right screen or not?
We've got, we see the PowerPoint. It's there we go. Now it's full screen.
Okay, excellent. Delighted to be a part of this. A lot to cover, so let's jump right in. Every year, the American Cancer Society estimates incidence and mortality from cancer, and for 2025, the year we're in, 313,000 men will be diagnosed, about 35,700 men will die. And just to put that in perspective, because you know how hard we work with colorectal cancer, I mean, that's 7,000 more men than die from colorectal cancer each year. But importantly, the average age of those men who do die is 79.5 years. So the conundrum around prostate cancer screening is that it's chiefly a disease, not exclusively, in older men. 1 in 8 men will be diagnosed in their lifetime. 6 in 10 are diagnosed at 65 or older, with an average age of 67. But the risk of developing prostate cancer keeps going up with age. And this shows that distribution. Relatively few before 50, not none. And if you're in that young group, that's important. But starting around 55 to 59 and then peaking 80 to 84. And probably would keep going, but there are competing causes of death in that over 85-year-old group. Not only that does it occur in older men, but men with prostate cancer tend to live a long time. 5-year survival rate for localized and regional prostate cancer is over 99%. It's only when you're in that distant stage cancer where you see a reduction in that 5-year survival. But even there, over a third of men will live 5 years. And when you combine all stages, it's a very high 5-year survival. So you tend to be diagnosed a bit older than some of the other adult cancers and live a long time, particularly if it's at earlier stages. I want to talk you through some of the history of guidelines and how the guidelines have had a profound impact on really why we're here and why prostate cancer screening which had enormous enthusiasm, fell off the radar to some extent. And it really can be drawn to this USPSTF, United States Task Force 2012 guideline, which was, as the headline said, a recommendation against screening. They gave PSA screening a D. And here's a wonderful study that showed, and there are others, what happened in the instance of metastatic prostate cancer following these changes. So the big uptake of PSA screening occurred with the publication of the 1992 American Cancer Society guideline in response to a New England Journal of Medicine article by Bill Catalona and team. Saw this huge increase in the incidence of cancer, which was really because we were doing all these PSAs and finding a pool of men who had not been previously diagnosed. Pretty steady incidence. And then look what happened at the time of the USPSTF D recommendation. A marked decline in cancer, and followed by a rise in a decade, not that long after that, about 3 or 4 years after that, which has continued almost all with metastatic prostate cancer showing the rise. We can see a somewhat similar trend in cancer deaths. You saw that post 1992 increase, then a steady decline in prostate cancer deaths to an all-time low level. And then following the publication of the 2012 task force guideline, kind of an evening out. Interestingly, we haven't seen the mortality go up much yet, but we have seen a end of the decline of prostate cancer deaths. The 2010 ACS guidelines starts to outline how we should approach screening. For men at average risk, a discussion about uncertainties, risks, and potential benefits, so shared decision. And with men who want to be screened should have a PSA with or without rectal exam. And rectal exam does not play a critical role in screening at this point. This has been mainly done with blood testing. If the result is over 2.5, should be repeated annually. And if men are at high risk, should start earlier and screen every year. Who's at high risk? According to ACS, African American or African Caribbean men are at high risk, should start at age 45. Men with 2 or more first-degree relatives, which is a pretty high standard for risk, or men with a close relative diagnosed at an early age. Those families should be referred for genetic testing. BRCA is the most common germline abnormality found, by the way, and should consider screening as early as age 40. Well, although the task force, and I remember the day, by the way, where I was at a lunch and Mary Barton, who was directing the task force administratively, leaned over and said, "We're going to give PSA a D." And I said, "Oh, yeah, that's going to have a huge impact." And lo and behold, I said, "Why not a C? I think that's what it deserves." And in 2018, lo and behold, it went back to a C recommendation. Here is the latest task force guideline. Men 55 to 69 may choose to be screened with a PSA following a shared decision-making process. No particular comment on frequency of testing. While acknowledging that men of African descent and men with a family history are at higher risk, they did not recommend a different starting age or a different frequency the way the ACS does recommend an earlier starting age. I quoted from this guideline. I'm curious how you respond to this wording. Screening offers a small potential benefit of reducing the chance of death from prostate cancer in some men. However, many men will experience potential harms of screening, including false positive results, require additional testing, possible prostate biopsy, overdiagnosis, overtreatment, and treatment complications such as incontinence and erectile dysfunction. Patients and clinicians should consider the balances of benefits and harms on the basis of family history, race, ethnicity, comorbidity, etc., and other health needs. So if you had that dialogue with your clinicians, just as I outlined it here, I'm curious how many of you would listen to that and say, "Yeah, oh yes, PSA is for me." And it kind of illustrates one of the challenges of doing any sort of shared decision-making. It may sound like high-quality shared decision-making, but what you include in your communication can have a very big influence on whether someone opted to be tested or not. In fact, a new trial that published quite recently, I think this was this was published online actually a decade ago. There have been some updates since then. looked at much larger benefit from PSA screening, the European randomized study of screening, than we had seen in some of the trials in the United States, like the PLCO. This was men ages 50 to 74 in 8 European countries. They actually reported the outcomes for their core age group of 55 to 69. And as you might expect in a cancer that takes a very long time to cause morbidity or even cause symptoms, there were a higher number of cases diagnosed in the screening group than in the control group, with an incidence ratio of 1.91 at 9 years. And with time, due to presenting with symptoms, the screening group catches up if they present with more advanced prostate cancer. So 1.66 more in the screening group at 11, 1.57 more at 13 years. There was a risk reduction in mortality that was seen, took a while to see its full benefit. You don't see this at 4 or 5 years because I already showed you that the mortality is very low at 5 years. 0.85 at 9 years, 0.78 at 11 years, 0.79 at 13 years. If you adjusted for men who were randomized to be screened but didn't participate in screening, the mortality benefit was even greater, a 27% reduction in prostate cancer-related death. So about 1 prostate cancer death averted for every 781 men invited to screening, even more for those who are actually participating. A modeling study showed that with screening every 4 years in 1,000 men, you'd have 52 life years gained and 41 quality adjusted life years gained from screening. Again, you're screening often in older men, so there are some competing causes of death that comes along, and treating prostate cancer can affect symptoms as well. I wanted to walk through, though, one of the things about the task force and about the ACS guidelines is that they're both older, and the American Urologic Association screening guideline is more up to date. It's a high quality guideline. It was done very well. Let me show you their guidelines. I think it gives a little bit more depth and guidance. They do recommend shared decision making. They do recommend a PSA for those who screen. For men with a newly elevated PSA, very importantly, the test should be repeated before doing any other evaluation. Any sort of inflammation, just ejaculation can affect PSA. You should repeat the test without ejaculation for 4 days to make sure that it was a real elevation. They may begin screening and offer a baseline PSA between 45 and 50. And I really love this data about a baseline. A baseline PSA can be helpful for patients ages 45 to 49 with a PSA below the median. The risk of prostate cancer metastasis within 25 years was 0.85%. And if it's over 1.6 in the highest decile, you actually saw a very substantial contribution to the risk of dying in the next 25 years. For men at high risk, Black ancestry, germline mutation, strong family history, they recommended starting at 40 to 45. They recommended every 2 to 4 years, interestingly, in 50 to 69. Probably depends on how high that initial test was. And then patients may decide to discontinue screening or screen more or less frequently as their life situations changes. Prior to having a biopsy, patients should be aware that they might have a prostate cancer that does not require immediate treatment. That approach to treatment has changed the balance of risk and benefits. More and more now, we're using multiparametric MRI prior to biopsy with abnormal findings guiding the biopsy. But it doesn't mean that a normal MRI rules out the need for biopsy. I just had a patient who had a normal MRI and had cancer in 40% of their prostate, but you wouldn't have a directed biopsies. There may be a role for other markers like percent-free PSA, PSA density, and a new marker, the post-digital rectal urinary PCA3, particularly if you're in this intermediate phase where you're not sure if you're going to do a biopsy. Finally, every guideline, as you can see, recommends shared decision-making. But as I mentioned earlier, the content and emphasis of the shared decision-making can and do vary substantially. And what worries me is that there are lots of studies, we just did a literature review, that I'm sorry, going to the last bullet, that primary care shared decision-making often does not occur, and the quality is usually quite low. So the third bullet points out that if you're going to do shared decision-making, a validated decision aid, making sure that the content reflects modern day estimates of benefits and risk, which is critical. It's not an out-of-date decision aid, can help in shared decision-making. So where do we go from here? I think we need to recommit to offering PSA screening. We've never recovered from that USPSTF 2012 guideline. We need to embed decision aids and clinical prompts into our electronic records. And primary care clinicians should become more comfortable with managing elevations in PSA, at least know the basics, and perhaps as far as getting the multiparametric MRI before referral to urologist. And our ultimate goal is to continue to improve the balance of benefits and harms of screening so that screening can be safely recommended for everyone without the need, perhaps someday, for a shared decision. Thank you so much.
Thanks so much, Dr. Wender. That's really, really useful information. So we'll turn it over to Dr. Rebbeck now to talk about the epidemiological considerations and some of the biology underlying the PSA test.
Apologies. Thank you everybody, very much, everybody. I'd like to drill down a little bit on some of the points that Dr. Wender just made to sort of help us understand what the future looks like and how we may be able to inform and refine the way we think about prostate cancer screening. So I'm going to, remind you again what you just heard, that the goals of prostate cancer screening are to find the cancer early before it spreads, but we also want to minimize harm. We want to avoid overdiagnosis, overdetection, particularly of slow-growing cancers. And this has to happen, I think everyone agrees, in the context of informed decision-making so that we can balance the benefits that might come from the screening against the risks that I'll talk about again a little more, with personal values, personal choices that the patient has. So the first point I want to make, and I think this is clear to everyone, that prostate cancer is extremely common. These are data that have been reported about a decade ago, showing the autopsy prevalence of prostate cancer. So these are men that underwent autopsies in research studies. This is a meta-analysis of those, showing the background rate of prostate cancer that is present in men who died of other causes, not causes that are associated with prostate cancer. So these are men that have just been found incidentally to have prostate cancer. And you can see that among Asian men in their 50s, 17% of them have prostate cancer. 27% of European or white men have prostate cancer. 40% of African men have prostate cancer. And in fact, you even see 8% of white men have prostate tumors in their 30s. So if you screen, you will find a lot of prostate cancer. And that's fine, except that most prostate cancer is indolent and doesn't need treatment. So it's very important for us to keep in mind that if we look for it, we'll find it. Not all of those tumors should be treated. And the downside, of course, the potential harms of screening, particularly of tumors that will not cause death, there's a lot of psychological impact, anxiety from false positives, and a cancer diagnosis is not going to ever harm you. Biopsy complications, which are somewhat rare but still present and certainly should be avoided if they're not necessary. Treatment side effects, as that you are very, very well aware, treatment can lead to incontinence, erectile dysfunction, bladder and bowel problems. Again, maybe reasonable choices, maybe reasonable things if you're saving your life with a treatment of a prostate cancer, but certainly not side effects that you want if you were diagnosed with a prostate tumor that was not going to cause you any long-term harm or mortality. And so this overdiagnosis and overtreatment of cancers that would never cause harm are really critical issues. So as you heard from Dr. Wender, there have been a lot of observations on PSA screening that have led us to where we are. So in the late 1980s, we certainly had PSA becoming common In the early 1990s, as you heard, the incidence rate rose dramatically, as Dr. Wender showed the plot of, followed by a subsequent decline. In the mid-1990s, mortality began to decrease, and more early type cancers were found. But in the early 2000s, most of the prostate cancers that were detected were localized. So there was a clear stage shift, and that reflects what I showed you in the previous slide. We're finding a lot of cancers that were localized, probably indolent. And at the same time, in the early 2000s, we found a number of randomized clinical trials that reported that showed whether mortality benefit was associated with PSA screening. And since then, the USPSTF and other recommendations emerged that Dr. Wender presented to you a minute ago. So what we've seen in this trial evidence is that here are some of the main trials that have informed the use of PSA screening: the PLCO, the ESRPC, CAP in the UK, Göteborg trial in Sweden. What you can see is that only the ESRPC and the Göteborg trial in Europe showed a difference in mortality reduction. The study in the United States and the CAP in the UK don't show any difference. But so I think that, and there were a lot of reasons why this is. Some of the trials had a lot of contamination in the United States of PSA that was being done outside the trial. I think that many people believe, who are looking at the totality of these data, that there is a benefit for PSA screening in reducing mortality. But how you use that PSA screening is what's important. That's what I'd like to focus on next. So if PSA screening has unclear mortality benefit overall, or it's not completely clear how much benefit it may have or in what groups, and may cause greater harm than benefit to some, can we find better ways to screen? And the answer, I think, is yes. But what you'll see in what I present is that there are costs associated with improving by risk stratification the way we screen. So as you heard a minute ago, digital rectal examination is there, but I think that most people don't believe now that DRE by itself has any added benefit based on data that we've seen. And very importantly, DRE may pose a barrier to some men to have screening without providing clear overall benefits. So the benefits of DRE are fine to consider in the context of a PSA test, but if men think they're going to undergo a DRE and don't get screening as a result of that, DRE may be a negative, maybe a barrier without any clear benefits. I think most people feel at this point that DRE is something that isn't necessary, particularly in a screening context, may be relevant in a diagnostic context. And the messaging may end up being, it's a blood test, not a finger test. That should be used in thinking about how to screen for prostate cancer, and that messaging, that information needs to be refined. Now we're thinking about risk adaptive or risk stratified approaches. And so you heard a little bit about that in Dr. Wender's presentation, where we're thinking about how to maximize the benefit while not and minimize the harms by thinking about the changes, the use of these tools by age, by genetics or family history, by race or ethnicity, by anthropomorphics. So some of these factors aren't easily modifiable, but they may serve as stratifiers in screening protocols. And risk assessment tools exist that may help guide screening decisions, but we need better and more user-friendly tools to really make the most of these approaches. So let me go through a little bit of what we know. So first of all, you heard a little bit about germline genetics. We know low penetrance cancer genes have been identified. There are about 450 low penetrance genes that have been identified through genome-wide association studies and others that explain about a third of familial risk. It's not clear what these genes' usage is in a clinical practice. They do identify people that are at increased risk of prostate cancer. They don't identify men who are at increased risk of fatal prostate cancer very well. So it's not entirely clear whether knowledge of these low penetrance genes will just identify more indolent tumors or more prostate cancer aside from those that need treating, et cetera. So a little bit more work needs to be done to really understand how those genes can be used. We also know there are a number of high penetrance genes that lead to hereditary patterns of cancer. The ones that we really are focused on are BRCA2 particularly, but also BRCA1 and HOXB13, some of the Lynch syndrome genes, and P53. So if you test positive for some of these high penetrance cancer genes, you should seek specialist input because there are very clear protocols for management of risk, treatment in cancers that arise that may involve targeted therapies, et cetera. So the genetics plays a very important role. But these hereditary high penetrance cancer genes are relatively rare in the population and should be referred to a genetics expert. As you also heard, there are a number of approaches that might be used to improve the PSA testing performance, like complexed PSA or percent-free PSA, other tests like the PCA3 or the 4K. There's a number of other scores, and PSA velocity that showed the changes in PSA over time, perhaps an elevation and an acceleration of PSA levels with time. Right now, it's not entirely clear that these have added value over traditional PSA and in whom these tests might give the best information, but they are certainly of value and worth exploring on a lot of different levels. One of the reasons that PSA is complex and difficult to interpret is that PSA varies by a number of different factors. So we know that PSA increases by age, and in part this has to do with the increasing size of prostates, even healthy prostates. And as you can see on the top on these plots, the median PSA level increases with age. If you look at the top right, you'll see that BMI, as BMI gets higher, PSA levels tend to drop. That's the phenomenon of PSA dilution. So the more blood you have, essentially, the lower your PSA level, even if the same amount of PSA is being produced by a prostate. On the lower left-hand side, we know that the self-identified race or ethnicity has some very interesting phenomena associated with it, that at very young ages, Asian and non-Hispanic Asian or Pacific Islanders tend to have a somewhat higher PSA, but as you increase in age, the highest PSAs are seen in non-Hispanic Black men. And finally, on the right-hand side, you see some of these polygenic risk scores. PSA increases depending on your underlying genetic makeup in terms of what PSA that drive PSA levels. So again, I just put this up there to show that there are a lot of issues related to what PSA level you see and what it means for an individual, depending on their age, their BMI, their race, ethnicity, or perhaps their ancestry. There are also a number of other factors that affect PSA readings. So there are some that may raise PSA, as Dr. Wender mentioned. So advanced age, and enlarged prostate, prostatitis, recent ejaculation, vigorous exercise, urologic procedures, testosterone medications, and factors that may lower PSA. So if you're taking a 5-alpha reductase inhibitor, some herbal supplements, long-term use of aspirin, statin medication, thiazide diuretics. And you can imagine what the biology underlying each of these is. But suffice it to say that when you have a PSA level, PSA measure, and you don't consider all of these different factors or the demographics of the individual involved, you might make mistakes, particularly if you're choosing a very specific cut point, like a PSA level of 4. Well, that PSA level of 4 might mean something very different in someone who's taking a 5-alpha reductase inhibitor and is a very young white man or something like that, compared to somebody who's has prostatitis, who is an elderly Black man. The PSA level might mean very different things with respect to its prediction of the presence of a prostate tumor. So sort of with that background, obviously, we don't have most of these issues resolved in terms of how we think about the use of these factors, but they are starting to be built into the guidelines that are out there. So these are the most recent NCCN guidelines for prostate cancer screening. And as you can see, they are trying to take into account age, race, some of the other factors that are associated with different levels of PSA at different ages, what kind of a cut point might trigger repeat testing, a biopsy, MRI imaging, etc. And so that what we're really beginning to do is to refine the guidelines around an individual's specific situation rather than a blanket guideline for all men. And I think that really makes a lot of sense. But as you can imagine, we still have a lot of questions to ask. When do we start? Well, certainly, as Dr. Wender mentioned, a baseline midlife PSA at age 40 or 45 has been shown to have a lot of value in assessing future risk of prostate cancer. And certainly if you have a very high baseline midlife PSA, even if it's not high enough to trigger a biopsy, that might determine the cadence and frequency and the modality of your screening going forward. But when to start is still an open debate, and we assume that some men will want to start earlier, some men will want to have a more frequent a cadence of PSA testing. Some may be able to go for 5 or 10 years without a PSA, depending on some of their characteristics. And when do we stop? This is a whole debate. Right now, as you see in a lot of the guidelines, they say stop screening at age 70. And that's based on life expectancy and frailty and things like that. But as we just saw with President Biden, he stopped screening around the time of the guidelines in his early 70s, and now in his 80s he has metastatic prostate cancer. And so it's clear that not all one size fits all for when to start, how frequently to test, and when to stop. So as you can imagine, there are pros and cons to the complexity that I've just presented to you. So we can refine the clinical pathways to maximize benefit, minimize harms, like the NCCN guidelines are starting to do. But the cons are that this adds complexity to an already difficult process. So if you can master the NCCN guidelines and all the other changes that are coming along and think about how to speak to your patient about these complex decisions, and if you baseline PSAs and your risk factors and things like that, that adds a lot of complexity. And if we're talking about in a primary care setting where you have 3 minutes to talk about this and you need to go through all of these nuances and have the patient understand them, that's not trivial, even though you can imagine these risk stratified guidelines may be ultimately of value. So the final reminder is that PSA, this is not the enemy. It depends on how the information is used. So we often think, is PSA good? Is it PSA bad? PSA is just a test. And I think the most important thing for us to keep thinking about is that it's the information that we get from a PSA test guides us to do something. And we hope we make good decisions about how to guide the information, the action that we take based on a PSA test. But it might mean that you need to repeat the PSA test to confirm that the elevation isn't temporary. You might know that someone has prostatitis or an injury or something like that. But if you have an elevated PSA, that doesn't mean you should go right to biopsy. It means you should make sure that PSA is indeed chronically elevated. When do you refer to your urologist? When do you get a specialist involved? Is that something that is going to be different depending on the person and their situation? Are there additional tests involved to make a better decision? And when is a prostate biopsy something that is the next step? So again, one size does not fit all. It's difficult because one size doesn't fit all. It's much easier if you can say do X and Y will occur. That isn't the case in PSA testing. And so we really hope to keep in mind that PSA itself is one piece of information in a very complex environment of clinical factors, risk factors, demographics, and decision-making that hopefully lead to maximizing clinical outcomes and minimizing harms. So let me just end there and thank you for your attention.
Thanks so much, Dr. Wender and Dr. Rebbeck. Really quick comment here. That last slide that Dr. Rebbeck presented is basically the best setup I could ask for our next webinar, which we're holding on July 30th. And I don't know if you did that to make me the happiest person on earth, but that's exactly what we're going to be talking about in that webinar, is how to follow up on an abnormal PSA test and best practices for referring to urology, leading up to biopsy, maybe, and the use of MRI and some of those other biomarker tests. So thank you so much for that setup. So as a reminder, if you have questions, please feel free to post them in the Q&A. We already have several, so we'll try to get to as many of these as we can in the time that we have remaining. But let's start it off with, I think, maybe the most straightforward question before we get into some of the heavier discussion. But so we've been talking about PSA testing in the lens of, screening and leading up to diagnosis. But once prostate cancer has been found, if it's early enough stage and indolent, of course, you can recommend an active surveillance course to monitor the growth of that tumor over time. And PSA testing is, of course, very useful in that context as well. So what is the best time frame for cadence of PSA testing in an active surveillance situation? Is there data on that? Is it a patient by patient thing? Or what are your thoughts on that?
Rich, do you want to take that?
I mean, there are guidelines for both. Let me just talk about a difference in lingo. I occasionally hear people say watchful waiting versus active surveillance. Two different things. Watchful waiting is literally just that. You do not actively surveil the patient with serial PSAs. You watch for symptom emergence, and would be far more likely to do that in a lower risk prostate cancer or in an older person or person with comorbidities than you would in a younger person, or certainly if there were high risk characteristics like a high Gleason score or a high grouping for the prostate cancer. Active surveillance is just that. It's ongoing, both PSA, but also repeat biopsies. And there are guidelines, different guidelines for different groups. I don't know the guidelines off by heart. Usually when a person is in active surveillance, they are being then followed by a urologist who has expertise in prostate cancer management. The active surveillance is generally not being conducted or led by the primary care team.
And just to add, the active surveillance usually follows protocols. I mean, there are defined protocols for following patients under different circumstances. And so the active surveillance is kind of a more structured approach as opposed to watchful waiting. And I think the reason I kind of turfed that to Dr. Wender is because the cadence of testing is not entirely clear. As you saw in the NCCN guidelines, there's different levels of testing cadence even as before anything has happened. If you have an elevated PSA, the testing cadence really, I think, starts being more, well, you can be under an active surveillance protocol and actually formally follow that, but there's a little bit more judgment, clinical judgment, in terms of when the next phase, a biopsy or whatever, might occur. And so I think that I'd love to hear more from urologists about how they manage it.
Next webinar, right, Lucas? You're going to give us some active surveillance?
Yeah, pretty much next webinar. Yeah, so tune in on July 30th. Moving on to the next question, then, if there's a known family history of BRCA from a breast cancer screening sense, should male children be tested in their risk for prostate cancer? Basically, how do we integrate family history of other cancers into prostate cancer risk assessment?
Yeah, there are very, oh, sorry, go ahead.
Yeah. No, you hit I have some good points to make. I think they're good points, but you hit it first, Tim, and then I'll go.
Yeah, I mean, there are some really well-established protocols now for cascade testing, meaning testing of relatives of individuals who have mutations, or testing in individuals who appear to be at very high risk of carrying a BRCA2 or a Lynch syndrome mutation. These are well established in a lot of genetics clinics, and it is appropriate for men who are at risk of having one of these mutations and worried about their prostate cancer, but presumably also their pancreatic cancer risk or their colon cancer risk, to undergo this comprehensive testing and ensure that they've managed their cancer risk their genetically predisposed cancer risk in a comprehensive way. So it's usually not only prostate cancer that's considered, it's genetic risk for cancers that fit a syndrome. And there are protocols that can be followed, and you should refer to an expert.
Yeah, the only thing that totally agree with every word of that. The simple answer to your question is, should the family members of somebody known to have a BRCA mutation be offered genetic screening? The answer is simple. They should be. The age at which that should be done, I don't think there's a strong argument for doing it during pediatric years. I think 20 can be an adult and make an informed decision. And as Tim Wells said, that affects the risk of multiple cancers and difference per gender. And then you would need to follow those more intensive screening protocols. Final word about that. And a huge issue, particularly BRCA, but other genetic testing as well, is being under tested. We don't have enough genetic counselors to talk to everybody who might be at risk. And there's the NCI is now has a series of trials that they're going to fund, hopefully, that are going to be testing whether we can shift some genetic assessment into primary care. I can tell you, when I talk to primary care audiences, it's good news. We're going to move BRCA testing and Lynch testing into primary care. There's almost no receptivity to that. So we have a long way to go to getting there. But I think it's going to be needed because the indications are now so broad.
So we did discuss a little bit the cessation or the recommendation to cease PSA testing at age 70, but there's another question in here. Maybe we can elaborate on that a little bit more. The concern is basically, I'm paraphrasing here, but that the morbidity of testing and diagnosis is emphasized over the morbidity of having metastatic prostate cancer as an elderly person. What's the balance there, and what are the signals, what are the frailty indicators or quality of life indicators, life expectancy indicators that you look for in making this decision to offer a screening past the age of 70?
Yeah, I'll go quick first. I think Tim and I would probably answer similarly on this one. Almost anything in healthcare to say that there's an absolute age that applies to every human being, it's unlikely to be the most ideal approach. It may be a practical approach, but it's rarely an ideal approach. The reason why an absolute approach was used for prostate is just what the questioner was getting at. Going through the diagnosis, and particularly curative intent treatment for somebody, with prostatectomy at an older age, that's a big deal to go through. It has serious impacts on quality of life. And I've had patients who said it's the worst decision I made. I never should have been treated at an advanced age. So I think there does have to be an overall assessment using life expectancy tables, ideally, that look at, somebody who has a previous cancer, who has underlying stroke or heart attack, who has early dementia. These are not people who should be doing probably any screening, certainly not prostate at that age. On the other hand, is there that subgroup of the very healthy, vigorous 70-year-old where they should continue to be offered choice? And I think they should.
Yeah, I totally agree. And I think that what we have right now are some recommendations that were based on epidemiological data and not really on, individualized data that it took into account health status and risk and things like that. And I think that the arbitrary number of 70 is not appropriate for everyone. And we should really think about how to get better models that predict the benefit versus the potential harm in men who are being screened, and figure out what that screening cadence needs to look like and when you can truly stop. And in fact, there are probably men that can stop well before 70. And we don't know that yet, but we don't have a great handle on that yet, but there are men that really can stop before age 70. So who are those men, and what are the, the decision points and data we use to make those decisions?
I think 80, too old to screen almost everybody. And the likelihood that, it's hard to know what age we would have found an 82-year-old metastatic prostate cancer. That's a hard decision.
Right.
It's not the year before, right? I mean, this was prostate cancer that began years earlier. So that's always a hard decision. hard to
Yeah.
look backwards in a case like that.
For sure.
Yeah, so we are coming up to the end of the Q&A period. There's a lot of great questions that I'm unfortunately not going to be able to get to. It looks like we need to have a webinar on Gleason 3+3, Gleason 6 cancer just on its own. But one last, hopefully to the point question before we move on. Are there any supplements that increase PSA levels that might influence interpretation of the PSA screening test?
Yeah, there's a lot of epidemiological studies that suggest some factors may increase. And, I think that we don't have a really strong handle on how much of the increase there is and what kind of exposure is required. But the kind of exposures that have been studied include vitamins, folic acid, multivitamins, B12, calcium, zinc. There's a lot of things that have been suggested as increasing PSA levels. Are those data sufficient to say your PSA is 4.1, but you're taking vitamin B12 supplements, so we're gonna, treat you, can manage you differently? I don't think we're there yet, but it's something for us to keep in mind as you're sort of taking the whole picture of an individual, and you're trying to decide how much of this PSA might be elevated because of something that has nothing to do with prostate cancer. If you want to take that into account, that's fine, but I don't think the evidence base is strong enough to make an action decision based on a PSA level at this point.
Lucas, do we have 40 seconds for me to grab one of the questions?
I think we've got 40 seconds.
40 seconds it is. Go. It was a question about when can we expect prostate cancer screening to be a UDS measure for community clinics or a quality measure. I really like that question. Here's the reality. As long as right now, for the reasons you've heard, shared decision making, no one disagrees. Shared decision making is in every guideline. And you can't do a quality measure if the answer is not 100% or 0%. So the answer is no time soon. I do not expect to see a quality measure for PSA screening. And it illustrates both the good things about quality measures, we really pay attention to them, but also some of the risks of quality measures. If it's not a quality measure, doctors tend to pay less attention to it. We're seeing that with lung cancer screening. So it's not recommending shared decision making is not the same as recommending skip it altogether. It's saying you should have a discussion with men using shared decision. That's what the guidelines say, not you decide whether to bring it up or not. So I'll just leave it at that, but I don't expect it to be a quality measure, and you shouldn't either anytime soon.
Thank you so much, both of you. This has been a really fantastic discussion, and I think been very helpful. So we're going to put up our post webinar poll now. Again, please take the time to respond to these questions. We'll give you just a minute here before I move on to our wrap up. We still got a few responses coming in, but I'm going to feel free to keep filling out those questions. I'm going to move on to the next slide just to give us a little bit of time to talk about this. I mentioned earlier that this is our first webinar. It's certainly not going to be our last. We have another one coming up on July 30th, as I mentioned previously. It's going to cover a lot of information that we led into very nicely with this webinar, and some of the questions that came in that we weren't able to get to in the discussion portion. I think we'll be able to address some of that in this webinar too. And if we don't, then we'll set up another one to tackle some of the other topics that came up. So please do feel free to use this QR code to register for that now. We'll be sharing it again later in our follow-up email. And then just please stay in touch with us. We have our website, all of our social media, and a newsletter sign up on this slide. We'll be sending out the slides and the recording to you within a few days of the webinar here. So please keep in touch, please keep following us, and we'll continue to hopefully provide you with some great discussions like this one today. And so I want to take a moment here to profusely thank Dr. Wender and Dr. Rebbeck for their time, for lending their expertise to this discussion. And thank all of the people behind the scenes who helped to put this webinar on as well as ACS and our funders, and all of you for coming. So thank you for joining us today. We're very happy to have you with us, and have a wonderful rest of your week. Thank you so much.